All right, welcome in. As your OB exam coach, we are going to cut right through all the noise. We're going to focus on that high-yield, absolutely must-know information that keeps mom and baby safe and, you guessed it, helps you crush your exams. This, right here, this is the question. It's the one you'll be answering in your head every single shift. It's the core of safe nursing, and frankly, it's what every single exam question is really trying to ask you. So, let's master it, right now. Okay, let's dive in. But first things first, we have to build our foundation. You can't possibly spot what's abnormal if you don't know what normal looks like, inside and out. So we're starting with the basics of how labor even works. I want you to remember these 5 factors. Think of them like 5 gears in a complex machine. For a smooth, successful birth, they all have to mesh together perfectly. Exams absolutely love to test you on this. They'll ask, what happens if one of these P's is off? What if the passenger is too big for the passageway? Or what if the powers just aren't strong enough? That's when you've got a problem. Okay, pay attention, because this is a classic NCLEX trap. It's so easy to get tripped up here. So here's the bottom line, the one thing you need to tattoo on your brain. True labor causes cervical change. That means dilation, the opening, and effacement, the thinning. If that cervix isn't changing, it is not true labor. End of story. All right, so we know what true labor is, but how do we actually track it? How do we measure that progress? This is the literal language of labor and delivery. It's how you're going to communicate all that critical info to the rest of the team. So we document this in a specific order: dilation, then effacement, then station. When you hear a nurse say she's 580 and -1, this is what they mean. The cervix is 5 centimeters dilated, it's 80% thinned out, and the baby's head is still 1 centimeter above this key landmark in the pelvis called the ischial spines. You can think of 0 station as that point of no return. The baby is engaged, and it's all downhill from there. The positive numbers mean baby is coming down and getting closer.
And now, for the main event, the fetal monitor. That paper strip is your direct line, your only line of communication with the baby. It tells you their story, beat by beat. You have to be fluent in this language. It's absolutely non-negotiable if you want to be a safe OB nurse.
The very first thing you do when you look at a strip is find the baseline. Just look at a 10-minute stretch and figure out the average heart rate. Now, that sweet spot, the normal range, is between 110 and 160. If you see a baseline consistently higher or lower than that, well, that's tachycardia or bradycardia, and your alarm bells should be ringing.
Okay, lean in for this one. If you only remember one thing from this entire explainer, I want it to be this: moderation. You see those beautiful little squiggles, the up and down fluctuations from the baseline? That is the most reassuring sign you can see. It's telling you, loud and clear, that the baby's brain and nervous system are getting plenty of oxygen and are working perfectly. All right, so we know what good looks like. Now let's talk about the scary stuff. This is where we separate the, oh, that's interesting, from the, oh my gosh, we need to do something right now. This is where you earn your stripes as a nurse. So you see the contraction go up on the monitor, and at the exact same time, the baby's heart rate takes a little dip. They mirror each other perfectly. When you see that, I want you to think head compression. It's just the baby's head getting a little squeeze as it moves down. This is totally expected. Don't panic. Now this is a whole different story. If you see a sharp, sudden, V-shaped drop that can happen anytime, I want you to think cord compression. These look scary because they are scary. Every time you see one, it means the baby's lifeline, that umbilical cord, is getting squeezed shut. That's a priority. You have to intervene immediately, usually by changing mom's position to get that pressure off the cord.
And this is the one we all dread seeing: a late deceleration. The key here is the timing. The contraction peaks and starts to go away, and then the baby's heart rate starts to drop. That delay is the biggest red flag on the monitor. It's screaming at you that the placenta is getting tired, that it's not delivering enough oxygen. This is a true emergency.
So how do you keep all of this straight when things are getting crazy and the pressure is on? You use this tried and true mnemonic, VALCOP. Seriously, burn this into your memory. It will save you on your exams, and it might just save a baby one day. Variable is cord, early is head, accelerations are okay, and late means placental insufficiency. So we take all those pieces, baseline, variability, decelerations, and we put them into 3 categories. Category 1 is beautiful. That's our goal. Category 3 is a full-blown crisis, and we need to act now. But here's the secret. Most of your day as a labor nurse is spent looking at Category 2.
It's that gray area, that I'm watching you zone. Your job is to watch it like a hawk and know when it's starting to tip over into trouble. Here is a huge red flag related to the powers of labor: tachysystole. Simply put, it's too many contractions. More than 5 in a 10-minute window is too much. Why? Well, imagine you're the baby. That break between contractions is your only time to rest and get a fresh supply of oxygen. With tachysystole, it's just squeeze, squeeze, squeeze. There's no recovery time. It's a direct path to placental insufficiency and fetal distress.
So, you see that Sperry Category 3 tracing. You see those persistent late decelerations. You don't just stand there. You don't just pick up the phone. You act. You are the first responder. These are your priority actions.
And here is your 4-step playbook for what to do. 1. Reposition mom, usually onto her left or right side. Why? To get the weight of that uterus off her major blood vessels and improve blood flow. 2. If she's on pitocin, turn it off. Stop the thing that's causing the stress. 3. Open up her IV fluids for a bolus. We want to increase her blood volume to perfuse that placenta better. And 4. Give her oxygen, 8 to 10 liters through a non-rebreather mask to maximize every molecule of oxygen we can get to that baby. These 4 steps can literally reverse fetal distress and are always the right first answer on an exam.
Okay, let's bring it all home. After everything we've talked about, what's the one combination, the one pattern on that monitor strip that should make your stomach drop, the one thing you will never, ever ignore? Think about it. The answer is absent variability combined with recurrent late decelerations. A flat baseline tells you the baby has no more reserve, no more fight left, and the lates tell you the placenta is failing. It's the ultimate fetal distress signal. That is your call to action.